And although one could say that this process of requiring prior authorization is curbing unnecessary services and reducing waste, slowing the growth of healthcare spending, the serious consequence that patients should not tolerate is that necessary medical services are being limited. And this is leading to expensive downstream care, and it is facilitating healthcare disparities.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Rowe Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello, and welcome to UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Rowe Urquhart, and welcome to this episode. I thought I'd open this episode with a little story. It's probably not a story, more of an anecdote / reflection, an incident that occurred in our practice only a couple of weeks ago. Our practice serves a call for a busy level 2 trauma center, and an individual presented to the emergency room with an anterior cruciate ligament tear, an ACL tear. And additionally, the patient couldn't bend his knee. With this in mind, the first thing that would come to mind is that in the presence of a really big swollen knee and a traumatic injury and inability to move the knee, that there must be something blocking the knee motion. And usually that is a meniscus tear. The patient was injected with an anesthetic inside the knee joint to reduce the pain and discomfort of the injury, and a forcible manipulation was then performed of the knee joint to reduce the meniscus. The patient had radiographs, including x rays and an MRI, and the radiographs and MRI were consistent with a meniscus tear as well as an anterior cruciate ligament tear or ACL tear. The definitive treatment for this patient would be surgery, and this surgery should be performed within a couple of weeks, ideally, to prevent any sequela of having an insufficient ACL, like arthritis primarily, or further injury and instability. And we presented the case to the patient's insurance company for authorization, what's called prior authorization. And fascinatingly, the prior authorization was not given. In the conversation for the appeal, which it takes 72 hours to appeal this type of decision, our practice was told that in order for the patient to get approval for this surgery, the patient would have to have radiographic or MRI findings that were consistent with the clinical findings. And lo and behold, when we looked at the MRI report, the radiologist read that the patient had a genetically large meniscus or a discoid meniscus, but the radiologist did not read the meniscus tear on the MRI. However, given the fact that the patient presented to the emergency room with a locked knee and the person on the other end of the line was also an orthopedic surgeon, we would think that the orthopedic surgeon on the other end of the line would know that by definition, if the patient had a locked knee, that there was a meniscus tear involved in addition to the ACL tear. At the end of the day, we were told that we had to have both the radiographic findings, so we would have to have either the radiologist amend his reading of the report, as in addition to the clinical findings, in order to get approval for both the ACL reconstruction as well as the meniscal treatment, be it repair or debridement. And we were floored when we were also told that In order to get approval for the ACL reconstruction, we would have to accept removal of treatment of the meniscus as a part of the surgery. Wow. I can't believe this is the state of healthcare. We have a condition that an orthopedic surgeon would recognize as being what is required for surgical treatment. And we have an orthopedic surgeon on the other line who essentially says that if you don't accept not treating the meniscus as a part of this surgery, we won't approve the surgery. End of statement. So, the topic of today's chapter is prior authorizations. I've been told by non medical folk that this is very sophisticated medical terminology. I didn't know that. Prior authorization, I thought everyone knew what that was. I consulted an article. There are a couple of articles I'll talk about today, but this one is written by Eugene Yang and Shushan Yang. And they're actually cardiologists, and they talk about prior authorization and the overwhelming burden and a critical need for reform. So, in this particular article, which was published in 2020, Dr. Yang says high healthcare expenditures in the United States have prompted health insurance carriers to increasingly rely on utilization management strategies. What does that mean? That means they want us to use healthcare less. They're trying to tamp down on the use of healthcare to reduce the cost of healthcare. So they want to collect premiums at the stable level, collecting premiums, that's the income, and then minimize expenditures by reducing utilization, or the sophisticated term would be utilization management. And so, one of the strategies that has been employed to facilitate utilization management is prior authorization. And the outcome would be, of course, to lower cost or lower expenditures. So, again, continue to have revenue from premium payments and contributions from employers to the insurance plans, but reduce the expenditures or the costs by employing utilization management. So the thought here is not necessarily to improve patient care or to expedite patient care, but again, to manage utilization. And Dr. Yang goes on to say this process is plagued by inefficiency and overwhelming administrative burden at the expense of patient safety. Patients wait for decisions regarding coverage approval for days or weeks. And I can say, yes, that is true, days or weeks, only to find that their coverage is denied. But what I was told is that the person on the other end of the line who's fielding the appeal, they don't want to use the term denied. When they refuse to provide prior authorization, they are refusing to provide prior authorization. They say, do not say that we are denying care. I can't believe the semantics there. And let's be reminded, prior authorization, as much as time and administrative burden as it takes, is no guarantee of payment. I repeat, prior authorization is no guarantee of payment. So there are reports of adverse patient outcomes resulting from prior authorization requirements. And this is very common. We are seeing more and more adverse patient outcomes. And I'm going to come back to this, but I want to go to a gynecologic oncology paper that was published in 2022. And again, gynecologic oncology, so that would be cancers of the female reproductive system. And what they found was they looked at certain visits, patient visits, exactly 2,112, and there were 1,406 patients involved in those visits. 5% of them experienced prior authorization during the study period, which was 3 months. Again, around 2,000 patients, 2,000 visits, around 1,400 patients, 5% of which experienced prior authorization. And then an additional 20% faced prior authorization requests earlier in their cancer care, but not during the study period. Of the 83 prior authorization requests, imaging, which significantly affects orthopedic surgery, accounted for the majority, 54%. Medication, 29%. Chemotherapy, 17%. So even chemotherapy, life-saving treatment, requires prior authorization. Now, who in their right mind would take chemotherapy if they didn't need it? Okay, that's where we are right now. So, the results of this were that a certain percentage of these prior authorization requests had to go to appeal. And for those patients that went to appeal, almost 80% of the cases were approved. But you can imagine we're looking at a delay here. The time that it takes to get the prior authorization, and then you add the time that it takes to appeal, we're looking at least a week, maybe more. So, yes, they say for those patients whose prior authorizations were approved, it was a mean of 16 days from order placement, meaning entering into this prior authorization process, to care delivery. So the range was from 0 to 98 days. Of those that were denied, there were 17 of these claims that were denied. 18% led to a substantial change in care, meaning the patient did not receive the planned treatment. And what is so fascinating in this scenario where the prior authorization is not given, patients may actually decide that they don't want to have care at all. They would rather deal with the pathology of their disease. And you can imagine having gynecologic cancer and opting not to have care at all because it's not affordable and the prior authorization was not given. Going back to the previous article, again, Dr. Eugene Yang and Shushan Yang. So they talk a bit about adverse outcomes, or meaning, problems that occur for patients because they don't get the care that they need because of this whole prior authorization scenario. To prevent adverse outcomes, clinicians must invest, and I will second this, significant resources to ensure that appropriate care is accessible to patients. So we're not the gatekeepers, but we're the ones that are advocating for our patients, trying to get their medication approved. In the gynecologic oncology scenario that I just quoted, their cancer treatments, their chemotherapy approved, their imaging to determine imaging's critical in cancer care because we need to know where the tumor is, what are the margins. If we're going to do surgery, where do we start and where do we stop? We don't want to take tissue that we don't need to take, but at the same time, we want to get the cancer. Whose side are we on? The patient or the cancer? We need imaging. Physicians and staff in this paper, Dr. Yang's paper, spend over 20 hours per week interacting with health plans. I would say that's far higher for the number of staff that we have in our practice, especially because we're orthopedic surgery and we have imaging involved. We interact with insurance health plans on every facet, and significantly more than 20 hours per week, staff hours per week are involved. But given the 20 hours per week number, this translates to an annual opportunity cost of approximately $70,000 per practice. And that depends on where you are because minimum wages are different in every state. And our staff make far above minimum wage and $31 billion nationally. That's just an estimate. And there is a citation there for the 31 billion. So the amount of time wasted on these non-clinical activities is a leading cause of physician burnout. I can say amen to that. Physician and staff burnout. You just feel like you're fighting a losing battle. So there have been some bills that have gone to the Senate where prior authorization reform have been passed. One in the state of Ohio, streamlining the prior authorization process, mandating disclosure of the requirements for prior authorization approval. Can you believe we don't even know what the requirements are? And that's constantly changing. And providing a 30-day notice of any new requirements before implementation. So that's Ohio. Delaware also enacted some reform following a 2011 case that generated national attention. And this was a situation where a patient was denied a nuclear stress test despite two physician appeals. The patient presented to the emergency department 35 days later and underwent urgent coronary artery bypass surgery. And so, as a result of that patient's trauma and morbidity, Delaware passed a bill. And so, we're looking at states potentially helping with the issues of prior authorization. But I think the main thing that we need to talk about is, again, this concept of utilization management. The motivation for this prior authorization journey is not improving healthcare for patients, but rather managing, or it's really minimizing utilization. So it's not utilization management, it's utilization minimization. So even Medicare has gotten in on this. Medicare Advantage insurers, which cover over 48% of Medicare beneficiaries, commonly use prior authorization to manage spending and use for their enrollees. And this paper was published in 2022 in the Journal of the American Medical Association, or JAMA. And it says an estimated 99% of Medicare Advantage plans require prior authorization for at least some medical services. And the use of prior authorization is also increasing in traditional Medicare. Historically, traditional Medicare did not require prior authorization, but given the success of the, again, utilization management or utilization minimization, even Medicare is getting in on this. And although one could say that this process of requiring prior authorization is curbing unnecessary services and reducing waste, slowing the growth of healthcare spending, the serious consequence that patients should not tolerate is that necessary medical services are being limited. And this is leading to expensive downstream care, and it is facilitating healthcare disparities. We need to look closely at this prior authorization because it has very serious potential harms. That these insurance companies are not beholden to the Hippocratic Oath, so they can apply clinical practice guidelines inappropriately and trigger inappropriate denials of healthcare services. As well, these prior authorization programs tend to be poorly administered and implemented. And these waiting periods, these mandatory waiting periods and prolonged waiting times can result in further delays. And I'm going to stop there because I just want to tell another story. So, this was many years ago. We had a patient who was in a managed Medicaid program, so she was covered by the insurance that was provided and some partially supported by the federal government managed Medicaid program. And she presented to the emergency room with an ankle fracture. She was a tween. She's probably 11 or 12 years old. And generally speaking, what we like to do with those cases is if it does require surgery, if the ankle is unstable and it does require surgery, we'd like to do the surgery right away. Because of her insurance, she was actually sent out with a splint and told to find an orthopedic surgeon in her insurance plan. And at that time, we were in her insurance plan in our practice. And unfortunately, though, it took her almost 2 weeks, which is when fractures begin to fully heal, almost 2 weeks for her to find us. When she found us, we put on the accelerator. We got to the insurance company. We let them know that this was an urgent treatment that needed to take place with this young lady in order for her to be able to walk properly in the future. We needed to get an urgent prior authorization for her surgery. We went ahead and booked a case. The OR was ready and set up on the appointed day. And given the time frame of the urgent approval prior authorization, we were ready to go. We had the trays open. We're standing in the OR, ready to go. And then we get a call from the business office of the hospital where the surgery is to take place. Now, again, I want to remind you that this is a minor, so her mother had to take time off of work. The minor had to miss school. Everyone is in place. Obviously, the OR time is valuable. The OR is booked and ready. Trays are open. We are then called into the business office and told that the insurance company refused to give the urgent prior authorization, had shuttled her case to a regular processing time, and she would not have authorization for surgery any sooner than 72 hours from the time in which all of this arranging had taken place. We called to try to get an appeal urgently, try to get someone on the line with the insurance company who had compassion for the young lady, for her family, for the potential outcomes for her recovery, and to no avail. The surgery did not take place that day. It had to take place the following week. Why? Because of utilization management. Utilization minimization. It didn't affect anything in that she needed the surgery. The surgery had to be done. In that the same OR resources were utilized the following week that would have been utilized that day. What were they hoping for? That she would change her mind and that she wouldn't need surgery for her ankle fracture? Utilization minimization. That's what needs to come to your mind when you hear prior authorization. And this is Medicare. This is managed Medicare. These are the private insurers. Tactic number 1, delay, deny. Let's just think about that. Unfortunately, there's more for us to talk about, and we will be talking about it in another episode, but I hope that I really enlightened you about prior authorization and what it means, how it affects us in clinical practice, and what you as a provider or a patient need to be thinking about when you hear those two words put together back to back. And it's not improving patient care and doing what's right for the patient. Thank you so much for joining me for yet another episode, another chapter of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart, and I hope that you are well, and I look forward to speaking with you next time.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.